Well, good afternoon, good evening, colleagues, students, friends, alumni. I'm Professor Daya Reddy, Vice-Chancellor Interim of the University of Cape Town, and it's my great pleasure to welcome you to this inaugural lecture, which is going to be delivered by Professor Lebogang Ramma, who is Professor of Audiology in the Department of Health and Rehabilitation Sciences in the Faculty of Health Sciences. It's a great pleasure for me also to welcome members of Professor Ramma's family here. We are very pleased to have you here with us. Let me introduce the members of our platform party. So on my right, we have Professor Roshan Galvan, who is the head of the Department of Health and Rehabilitation Sciences, and she will shortly introduce our inaugural lecturer. Then on her right is the lecturer himself, Professor Lebogang Ramma, in case you wondered. And we then have Dr. Lucretia Peterson, who is the head of division of communication sciences in the department, who will deliver the vote of thanks after the lecture. And we then have Professor Elelwani Ramugondo, who's the Deputy Vice-Chancellor for Transformation, Student Affairs and Social Responsiveness. And last but not least, of course, is the Dean of the Faculty of Health Sciences, Associate Professor Lionel Green Thompson. So, colleagues and friends, inaugural lectures are a special event in the life of the university. They mark the ascent to the rank of full professorship, which is the highest academic rank that can be achieved, and one that is aspired to by any serious scholar. So whether one is promoted to the rank or appointed to it, it is an arduous procedure, and those who have achieved this rank will tell you exactly that. But it constitutes recognition. It's tough, and it ought to be tough because it constitutes recognition of the stature of the individual and a recognition also of the high quality of their work, their scholarship, teaching, their research work as well, and the impact of their academic work. Inaugural lectures, such as the lecture this evening, provide an opportunity to celebrate the achievements of the lecturer, of the new professor. They provide an opportunity for the lecturer to share insights into their scholarly work, what it is that they do, what it is that they profess, and to do so in a manner, given that we have a general audience here, in a manner that is accessible to a very broad audience. Academics in the health sciences generally have to find a balance between, on the one hand, studying, if you like, humans, the human body, medical conditions, increasing their and our understanding of it, and on the other hand, training health practitioners to diagnose and address these conditions. In the case of Professor Ramma and his colleagues, this is no exception at all. Their responsibilities lie in the domain of scholarship, broadly speaking, the range of activities that would straddle teaching, research, communication and application of knowledge as well. Activities that help advance the field of audiology in South Africa, but also beyond. Hearing loss is exceptionally prevalent across the developing world, especially throughout Africa. Although there are cost-effective preventive measures and interventions that would address hearing loss, they're available, but nevertheless they remain inaccessible rather, to large numbers of people who need those kinds of interventions in the developing world. This is a situation in which Africa often finds itself. Access to costly medical care, technology, vaccines, and the like. Professor Ramma has been active across the African continent, helping to develop audiology training programs in a number of countries, including Zimbabwe, Botswana, and Nigeria. Furthermore, he was instrumental in the development of the National Ear and Hearing Plan in Zambia. I now hand over the podium to Professor Galvan, who will tell us more about our inaugural lecture. Thank you.
Thank you, VC. So it's indeed an honor for me to introduce Professor Lebogang Ramma this evening. Good evening, colleagues, friends, family members, both here and those joining online. The story of Lebogang Ramma, fondly known to us as Lebo, starts in a village in Molepolele in Botswana, the traditional capital of the Bakwena tribe. Although Lebo's maternal side of the family hails from Mafeking in the Northwest Province, he spent his formative years in Botswana. Raised in a traditional family, were mostly traditional farmers, mainly involved in livestock farming, his career choice was more or less predetermined. Lebo was going to be a veterinarian. In a twist of fate, he was unable to secure a scholarship, luckily for us, to study veterinary medicine and was awarded a full bursary to study audiology instead. Lebo completed all of his audiology training in the United States, first at the University of Southwestern Louisiana, it's now called University of Louisiana Lafayette, where he spent just one academic year. Unable to acclimatize to the humidity of the South, he transferred to California State University, Fresno, where he completed his bachelor's degree in Communication Sciences and Disorders in 1998. He followed this with a master's in audiology and graduated in 2000. He then joined the Veterans Administration Hospital in La Jolla, California for a year, completing a fellowship in audiology before enrolling for his clinical doctorate degree in audiology, which he completed 3 years later in 2003. Lebo also held several positions during his stay in the US. The most notable of these was as an audiologist at the Riverside Medical Center. In 2004, he left this position to join the University of Witwatersrand. While at WITS, he enrolled in an MPH, Masters of Public Health program in 2006 at WITS, focusing on health policy and management. As though that was not enough, he also concurrently registered for the postgraduate diploma in health economics at UCT. This was the first year that the program was launched at UCT, and Lebo became one of the 10 students admitted as the first cohort of this program. He completed the postgraduate diploma in economics in 2008 and the master's in public health a year later in 2009. Embodying what it means to be a lifelong learner, Lebo is currently registered for another PhD in health economics this time, which he hopes to complete soon. Since joining UCT in 2007, he has served in different roles in the department, in the faculty, and the university. A list that will leave us standing here all night if I were to go through it. But notably, he's been the head of the Division of Communication Sciences and Disorders from 2012 to 2016, and we benefited from his wise leadership as a head of Department of Health and Rehabilitation Sciences from 2017 until 2022. Lebo is known to us for his easygoing, youthful, sometimes playful approach, and of course his reminders that we must not forget the men in our department. When not working, Lebo is spending time with his wife Zandi and his 3 children, Chiamo, Kumo, and Arinia. On Saturdays, he can be seen traversing the rolling slopes of Durbanville Hills, mountain bike trails. It gives me great pleasure to invite our dear colleague, Professor Lebogang Ramma, to deliver his inaugural address.
Good afternoon. Let me start off by acknowledging the UCT leadership, executive leadership, Professor Diaredi, our Vice Chancellor, and Professor Loren Ramogondo, Deputy Vice Chancellor. And I would also like to take this opportunity to acknowledge leadership of the Faculty of Health Sciences, led by Professor Lionel Green Thompson, and members of his executive. Colleagues and friends, I would like to acknowledge you and appreciate your presence to come and attend my inaugural lecture. But before I start, I would like to acknowledge my family, members of my family who are here. From KZN, I have the Zondi family, and the Zondi family exercised an act of bravery over a decade ago by handing over the baby of the family to some stranger who she met in Cape Town. And I'm so grateful that, yes, it's been now almost 14 years, 15 if you ask me, but we always, but I haven't disappointed them and I don't intend to do so. So thank you very much. So in thinking about this topic, I'm going to take you through a journey that I took in finally crafting my research focus. I came to UCT immediately after resigning from VETS. I had a bag full of dreams, ambitions, energy, and by all means, I considered myself a high flyer. And I got to UCT. Things changed very quickly, and I had to face the reality of research at UCT. So basically, in my presentation, I'm just going to take you, just a quick overview of what I do as an audiologist, and as I said, the early years of my research, and then finally coming to the reality of why do we need to research, a little bit on social responsiveness, and I'll end by sharing a little bit of what I'll be doing going forward. But I put the first part, or going into the first part, which is basically what I do, as an audiologist, because I realized that even my colleagues, some of my closest colleagues don't even know what I do. and I'll give you an example. And in some cases, even my family, because my son asks me these questions every now and then. So my very trusted friend, I won't say the name, and he's in this room. So, so we were meeting for the first time, and I was telling him that I'm an audiologist. So as they always do, he said, excuse me, huh? And every time when they do that, they get me. So I'll, compose myself, make sure that I enunciate clearly and speak a little bit louder. But usually after doing that, they just laugh back at me because it was meant to be a joke. I never get it. But in a very quick summary, I just want to hearing loss, much as most of us think that it's a benign condition, and in fact, for some people, we just accepted that as we get older, you are going to, lose your hearing and then just live with it and move on. It's not as benign as some of us would like to believe it. Currently, we have about 1.5 billion people who are living with some degree of hearing loss, and about 430 million of those people, that will be a hearing loss that is considered disabling hearing loss. In other words, if you don't do anything about that, you will feel the consequences of loss of hearing. And then in terms of contribution to the burden or contribution to the number of years lived with disability, hearing loss ranks up, I think it's the third as a contributor to the years lived with disability. And annually, governments around the world spend close to 980 billion in managing hearing loss. And those costs are spread across health sector, education sector, loss of productivity, and societal costs. Prof. Reddy, in introducing me, was talking about the accessibility of interventions for hearing loss, which in most cases is hearing aids. And this data is from the United States, one of the richest countries when it comes to healthcare spending. And you can see, even now, as of 2019, there were still about 16% who should be using hearing aids were having access to them, most of it being the cost. In South Africa, or particularly, let me just say in Cape Town, because most of these numbers from WHO are basically modeled. We did something. I was with this young man. He was then he was working at UCT at the time, Ben Sebotoma. He later went to Vets. He's now Dr. Sebotoma, so I have to make sure that I use the right title. So Ben and I decided that we will take our audiometers and literally go around Cape Town, the Cliffontein corridor, from here to Khayelitsha, going door to door, testing, and not just screening, but diagnosing hearing loss. And in our numbers, we found that about 12.35% of the people that we tested did have some degree of hearing loss. And like the WHO numbers, our prevalence of disabling hearing loss in the Cape Metro was nearly 5%. And here are the factors or risk factors for hearing loss. Age, obviously, when you get older, you will lose your hearing. That's just a fact. Family history of hearing loss, sex, self-reported history of hypertension, and so on and so forth. So those were the things that we found when we were going around screening people. And it was a very tedious and in some cases risky operation, because while we are testing, sometimes we have to be pulled into the house, be stuck under the bed because there's someone shooting in the street. And we did that over 6 months, but I'm happy to say that we managed to test over 2,000 people. And hearing loss, again, is, comes with comorbidities, or there are health conditions that hearing loss is one of its comorbidities. And I'll just focus on two here, which is diabetes and hearing loss. There used to be a suspicion that, diabetes is in some way, because of peripheral neuropathy and so on and so forth, could be associated with hearing loss. But over the years, we have conclusively, through several studies, including a study that was done by my master's student at the time, now my PhD student, who's about to submit in a month's time, Vera Tlaisi. She did an excellent study about 5 years ago, in which she went into a diabetes clinic in Limpopo, or a primary health care clinic that was managing patients who were coming in for diabetes management. And in her study, she found that over half of those people did have some hearing loss. And even more importantly, as I've mentioned before, the hearing loss that requires some sort of assistance or intervention was still prevalent in people who presented with diabetes. So the moral of the story here is, if you are a GP somewhere, or a medical doctor who works with patients who do happen to have diabetes, and in your management plan, you don't include screening for hearing loss, know that you are doing them a disservice, because it's not no longer, a suspicion. There are several studies, including this one, that I could confidently say that conclusively we found a a good number of people who happen to have diabetes as well. Hearing loss is a significant comorbidity. Then the other part that we could not shy away from is the hearing loss and cognitive decline. In most of our families, in African families, when we get, elderly people, I don't know which comes first, cognitive decline or the hearing loss, because when the hearing goes, we tend to avoid them a little bit. So you see Gogo sitting there and you just, hi Gogo, and then you tell people that, speak louder, they can't hear. But most of the time they are not, you don't interact with them like you used to, because now they find it hard to communicate. And if that is not attended to, the studies have shown that that can accelerate the cognitive decline. And about 3 years ago, colleagues from Johns Hopkins in Maryland did this, what we call a landmark study. Because the association between cognitive decline and hearing loss was established, what they wanted to do was, can we stop it from progressing rapidly? And so they get a group of people, some they fitted them with hearing aids. It was a study to try to find out the impact of, if you do intervene via hearing aids, can that in a way reduce the progression of cognitive decline? The results of the study were a bit ambiguous, but the part that came out clearly was that for people who have marked risk factors, who you know that this person is at a high risk of developing cognitive decline, over the 3 years in which they were fitted with hearing aids, it was found that fitting with hearing aids delayed cognitive change by about 48%. So it's not okay to leave, especially elderly people, if they can't hear, it's not okay to leave them, without any intervention. In most of our state hospitals, they can get at least 1 hearing aid. And for those who afford, they can even get 2 hearing aids, one being the one that they buy for themselves. So this is very important. And for the health-related quality of life, we need to take this into account for people who work with, and it's ironic that we are doing this lecture in the Neuroscience Institute. I'm hoping that wherever Prof. Figan is, he'll consider this and make it one of the things. Okay, then in terms of hearing, you know how the story goes. Hearing aids are not the most favorite assistive devices for most people. The story goes like this. First, you get eyeglasses. This is the process of aging. You age, you get eyeglasses, and then you get hearing aids. After hearing aids, you die. So people tend to avoid hearing aids. So, and that is not necessarily true. And I'm going to show you right now. So this is the first generation hearing aids. I think this was the one that could only be afforded by kings. And then the second generation, as you can see, the dames are now trying it out. And then this one, this is what we tend to associate with hearing aids. People say, I don't want that ugly thing in my ear. That's what I get a lot in, when you work with people who need to be using hearing aids. I'm here today to tell you that you don't need to worry about those ugly things. We are now here. Yeah, we are now here. So modern hearing aids. This hearing aids actually was introduced into the hearing aid market last year. I won't mention the company because I have some gripes with them, with the way in which they operate in the African continent. So I'll just leave it like that. So, but I'm putting it here to try to explain how delaying using hearing aid because they're ugly, whatever, you are actually not doing you are doing yourself a disservice, because this hearing aid, now, if you think about it, can do about 80 million adjustments in an hour. So whether you're in a noise environment or you want to focus on a particular thing, that translates into about 1.3 million adjustments in a second. That's really, really, really powerful in terms of processing power. And when I was studying, I mean, you'll be lucky if you had a digital processor, and for you to change to watch TV, you have to press at the bottom, and like it was just cumbersome to use hearing aids. No wonder people didn't like them. And nowadays, most of our colleagues, you probably have seen someone, even at UCT, I've seen a few colleagues who use hearing aids, and they are Bluetooth enabled, the phone rings, and they don't even touch the hearing aid. They just answer the phone and then transfer directly to the hearing. So hearing aids have moved a long way. And for this hearing aid in particular, not only do you get a hearing aid, you get an activity tracker. If you come in and say this hearing aid doesn't work, I just log it in and tell you that that's it's not working because of course you didn't use it because so I can tell you what you did. And most importantly, for some people who may need reminders, you can set your reminder in your hearing aid. You are wearing your hearing aid and it tells you time to take your medication. So hearing aids have moved a long way to a point whereby, just like phones, remember that nowadays when you buy a phone, you don't say, can it call? You say, what camera? Like you think about the apps. So that's where we are with hearing aids right now. So there's no reasons for not getting hearing aids. Those ugly things, their days are over. Even the affordability has improved significantly. So if you have a loved one who needs a hearing aid, please, rush quickly to get them assisted. So I think I've done a lot of public service for my profession, and I'm sure audiologists here will appreciate that. Let me now tell you how I fit into the picture. So as I said, I came to UCT very ambitious and wanting to do good in the society. And one of the things that I was really passionate about was the conditions in a classroom setting. Being a hearing scientist, this was something that was particularly very close to my heart. And it was stimulated by one of my professors at the University of Florida, the late Professor Carl Crandall. He passed away around 2006. He came in and gave this lecture. And it was so graceful. After that lecture, I said, this is going to be my life's mission. And coming to South Africa, I was at WITS, and armed with the legislation and the policies, I could see myself moving and shaking, grounds to make sure that learners get decent learning space by way of classrooms. But just to share with you, when you assess the condition of a classroom for listening purposes, you're interested mainly in two things: the amount of background noise and this constant called RT60. Basically, as I'm talking right now, my voice is coming to you and you would like to get the original sound from me, not the echo. If there's a lot of echo that is bouncing around, it will make my speech deteriorate, and then that is detrimental to listening. So what we want a room with a background noise of about 35 to 40 decibels in the A scales, more like a whisper. That is in an unoccupied setting, and the noise shouldn't bounce for more than a second. It has to be under a second. If you have that room, you know that you have a conducive listening space for learners. And particularly in South Africa, where almost all learners learn in a language that is not their mother tongue language. I have this from personal experience. When I was studying, they brought senior students to come and do some screening because, first years are usually used as guinea pigs. And I was diagnosed with a hearing loss because I couldn't repeat the words that the person who was testing me, who was a postgraduate student, I couldn't repeat them, in the way that she wanted me to repeat them. So she diagnosed me with a hearing loss simply because of the accent. So now, imagine our learners in South Africa. They are learning in, in many languages, sometimes not even their second language, but their third language. So a deterioration in the classroom setting was obviously going to put them at a disadvantage. So that's why I thought that I could pursue this. The law was on my side, and the policies were there to guide how I do this. So I started off by trying to assess the noise levels in our classrooms. This was a study done in Johannesburg while I was still at Wits, even though it was later claimed by UCT because I moved there. So I went into like different areas, suburbia. I went into township, like Middlelands, Soweto, and areas like that. And then I went into some schools that I could see that these schools are located next to a very noisy source. And I can tell you, none of those classes met the standards in terms of background noise. They were just way too noisy for obvious reasons, overcrowding and so on and so forth. Amazingly, there was one school, and surprise, surprise, it was an all-girls school in Athol, in Johannesburg. None of the schools came even closer to meeting the standards that are South African standards. So that school was the only school that could meet that standard. And then I wondered, to teach my family members here are educators, two generations of educators, so they can relate to this. So I thought, what do educators know or think about the acoustic environment of the classroom? Do they care? So like a well-meaning researcher, I went in and did this and spoke to them. And I must point out that yes, they, as expected, the majority of them didn't have what I considered adequate knowledge about this topic, or even the impact of poor classroom acoustics. They, at least the knowledge that I expected. Some obviously did. But what was interesting was the fact that they didn't seem to be particularly worried about this aspect. That was the least of their concerns. In fact, after presenting to them, I went to several schools. Immediately after presentation, they will thank me and then rush back to classrooms. And I was wondering, why are they not interested? And likewise, I was now at UCT and my colleagues were telling us that, Lebo, we don't even have basic research, man. We don't even know the prevalence of hearing loss in South Africa. Why are you running around doing this? But remember that I came here with a mission to shake the system and make sure that the learners are catered for. Then my world came to a shattering stop in 2009 when Sunday Times released this article. And it said that in 2017, the same report, virtually very little had changed as of 2017. I don't know where things are right now. This is the issue of mud schools in South Africa. There are learners who still learn in conditions such as these. And as you can see from the quote from one of the teachers, that we've lost hope that the state will give us any decent classrooms for our learners. So we do have learners at UCT, God forbid, who come from schools like these. So when we sit in our auditoriums and lecture halls, I think we should also not lose sight of this, that some learners or some students to get here had to go through things like this, unfortunately. And as if that was not enough, now imagine myself coming with my equipment, sound level meters and all that, trying to assess the acoustics of this classroom. Sounded ridiculous. No wonder teachers were really not interested in my, reverberation and, background noise, because for some, there were no classroom to talk of or to speak of. So this was really a wake-up call for me. And for a while, I was disoriented because I had set up this was going to be my life's work. So at this point, I had to decide whether I want to be a crusader for decent classrooms for students, or maybe focus on other areas that were suggested by my colleagues. And it was tough, it was not easy. But eventually I relented. I, now went into acquired hearing loss, and I first started with the socioacoustics. Socioacoustics is mainly loss of hearing from recreational noise. Most of the people, most of us are used to loss of noise as a result of exposure to noise at work, but here is just people having fun and in the process ending up losing their hearing. The first research that I did was around 2010. So as you can imagine, the Soccer World Cup was in South Africa. We did this. And the finding here was that, of course, the noise is excessive, in excess of 120 decibels. And fortunately, it's not a constant noise, it fluctuates. But when you go there, after that, for the next half an hour to an hour, your hearing ability will be a little bit depressed. But what surprised me the most, because I thought that it will be for people who are sitting in front of the vuvuzelas, the people who were actually blowing the vuvuzelas tended to have the steepest drop in their hearing during that time, which was, I couldn't explain what that was all about because I expected them to be the least affected. Just quickly, the other part, this is quintessentially a Cape Town thing. There are things called sound off. I don't know whether any of you have heard. So basically, you go into some shows, some car shows, and there are, young people with fancy cars, and they've fitted them with very loud music systems. And the goal is to play it as loud as you can. The loudest is the winner. Now, the way that they do it is that the driver has to get inside, close up the window, and then they put a little probe to measure the noise level, and then they tell him, just crank it. And then for some cars, especially the older cars, you'll just see the whole thing rattling. You don't even hear what's the whole car shake. And then there's someone inside. Very unfortunate, because you have to wonder about the intellectual capacity of someone who does that to themselves. But these are young people, right? So they do this to themselves, and this is only going to show up when they get to their 50s and 60s, unfortunately, and they can't even link it to this type of, recreational activities, if you can call it something like that. But for this one, I decided that no, this is not going to be a focus. First of all, it was very dangerous. The crowd was very dangerous. Just to give you an example, my colleague, Professor Gillian Ferguson, refused to allow me to go to a sound off contest. She literally drove me there, made sure that I did what I wanted to do, and then took me back, left me at Proteski and said, you can go home. And then so it's a rough crowd. And then secondly, the person who's affected is usually the person who's inside the car. So if we now think about population-based intervention, so that's the, yes, it's not worth the effort in terms of the amount of energy that you invest in trying to raise awareness about it. You can just, these are the people that you can actually, because here you can speak to crowds. Usually here it's individuals, and very crazy individuals, I must say. So the part where I enjoyed my research was when we were doing the Klopse. So we went to Bonteville, Menenberg, and Mitchell's Plain, and in some cases we even went to churches because we were doing all sorts of groups who were exposed to noise. And I must tell you, without dwelling on this, that in all, we tested over 60 people who do this almost consistently. And, like the amount of hearing loss in these people was no more different from, an average prevalence of hearing loss in a population. So this, in my view, is less harmful fun. And so we're coming with the machines and we're trying to do this. And then one of the guys, what are you guys doing here? So they suspected that we are going to, give some bad press. He said, please let my people blow. So, and I'm happy to say that they can do that. The part where I spent a lot of time, and not by choice, this was when they say when duty calls. There were a lot of research projects that were going around ototoxicity, just to frame this slide. Treatment, just normal treatment of certain health conditions, they have a side effect, or deafness as a side effect. So, for example, if you are being treated with high dose chemotherapy that involves platinum derivatives, you are more likely going to lose your hearing. And at the time, MDR-TB the treatment actually caused a lot of hearing loss in many people at the time. So in here, there was a lot of overflow of work, and we all needed to come together to do something. The evidence in terms of how to manage these patients was still lacking. So there were a lot of projects, a lot of colleagues, in fact, at UCT and other institutions were involved in here. And I'll just, quickly outline a few projects that we did or that I was personally involved in. Also to specify here that one of the things that we wanted to do was to quantify the extent of the problem and also try to see, are there any markers that we can identify that we can decide beforehand, before the person is being placed into treatment, whether they're going to lose their hearing when they start the treatment or not. So the first project was with this gentleman, MK Sibanda. He's now in Zim. He taught at the University of Zimbabwe for a little while, teaching audiology, and now he's in private practice. We went to Prof. Raj Ramasa. This is when I said, welcome to UCT, because it was now like high caliber research. So I brought my students, we met with Prof. Ramasa, and we worked out a plan. He introduced us to one of his students who was also a master's student, but a human genetics student who was working in a similar project, but of course from a genetics standpoint. We were coming from the hearing standpoint. And this was probably, in terms of collaborations, one of the best collaborations that I've ever been part of, because what he insisted, initially when we used to do this, we are used to, if you are collaborating with a geneticist and you're an audiologist, they will do their thing and then they will give you the data and say, here's the data. And in some cases, even write you a script to just add to. But what was different here was that Prof was adamant that MK must be part of the project in every sense. And he said, when he goes to a conference to present these results, when people ask him, he should be able to explain how he got to that. But what I'm sharing here is the numbers. The students did a retrospective review of folders in GSH. And as expected, we found that over 50% of people who underwent treatments during that time did actually ended up with a hearing loss, especially the people who were on high dose cisplatin. We did a similar thing at Brooklyn Chest. This was a pilot project that I did with a colleague from the University of Abuja, Professor Titus Ibekwe. And similarly, hearing loss was very prevalent in patients who were undergoing treatment for drug-resistant TB, MDR. So what you are going to see in the next few slides, I'll show you something from cancer patients and then MDR TB patients. So please stay with me as I do that. So we were now convinced that the numbers are huge. So the next part was, for these patients, you want to monitor them when they start treatment, check their hearing before they start treatment and then track them as they're on treatment, so that when you see any change in their hearing thresholds or their hearing level, you alert the treating doctor to say that this patient may be losing their hearing. Can you please do something if you can? Usually the doctor can, if there's another option, they will put them on a different medication that doesn't make them lose their hearing. In some cases, they'll alter the treatment to try to minimize the impact of, to minimize the side effects. And in some cases, there's nothing that they can do, especially for people who are in advanced stage of the disease, just to, counsel them and then the treatment continues. So we wanted to, and the problem at the time was that we struggled to monitor these patients. So we thought that maybe we can develop a questionnaire where the patients themselves can self-report whether they have hearing loss or not. And I was very disappointed because we found that the questionnaire was highly unreliable. And one of the symptoms is this tinnitus, the ringing in your ear. So when you include that, the sensitivity goes up, but the specificity, in other words, you'll pick up a lot of people, but a lot of those will still not have hearing loss. So it was still unreliable. So we abandoned the idea. So we also thought, and like this whole thing of if the doctor does this, does it improve or does it minimize the impact of the treatment or the side effects? We've always accepted it as gospel. In fact, when I was training, that's, even when I was teaching, that's what I told my students. But one day I asked, but do these things really work? And here, one of my master students, Zenzo Chagara, decided to tackle this question. And he went through the folders at GSH for patients who were on cisplatin chemotherapy. And unfortunately, we found out that for that cohort of patients, no modification made any difference. So, and there were a lot of reasons that we cited as that one of the key things is most of these people, you detected hearing loss very late when it was already too late to do anything about it. Because we did a similar study, which is not published, on TB patients, and we are using a very sensitive measure to detect hearing loss. And even though the sample was small, we did find, something that suggested that if you discontinue the toxic medication, then the hearing loss doesn't progress as much. Then still in, the Prof. Ramaz's group, then this work of trying to identify those genetic markers that you can pick beforehand and decide whether if I put this patient on cisplatin chemotherapy, are they more likely going to lose their hearing or not? And this gene, otos, which is found in the non-sensory part of the cochlea in the inner ear. The lead author or the lead researcher in this, in Prof. Ramaz's group at that time was a guy named Timothy Sprecken. I believe that Prof is no longer in your group. He went to the other group in the faculty. But he found that patients who had an overrepresentation of this allele didn't get as much hearing loss as those who, as the other patients. And it goes back to where you get a group of patients, they undergo chemotherapy, sometimes same dose. Some will lose their hearing and some didn't, even though it was in doses where you expected that some of those patients would lose their hearing, which clearly showed that it's not just about the amount of drug that they were exposed to. There are other things that determines whether they lose their hearing or not. That was the whole basis of the study. We didn't stop there. We tried the same thing in MDR TB patients. This is a study that is currently, we are writing this manuscript, soon to be submitted. And unfortunately for this study, it was not powered enough to make any conclusive statement about whether these genetic markers were any significant or play any significant role in terms of determining the risk of ototoxicity in these patients. And this actually followed a study that was done at UCT by other colleagues who identified these markers. And then I thought that for my student PhD, we will follow up on this and try to verify it. Unfortunately, we couldn't because of the sample power. And then just quickly, we also went into the pharmacokinetics of, in other words, we wanted to study whether the availability of this medicine, which at the time is kanamycin, which at the time was a very key component of MDR TB treatment, whether its availability in the blood plasma, its concentration that is in any way associated or determines the risk of hearing loss. And again, you will see the outstanding thing here, the most outstanding here is that many people in this study did actually present with hearing loss. And the point that I was making earlier about sensitive measures versus non-sensitive measure, here we're doing a very sensitive measure of detecting risk of losing hearing loss during treatment, high frequency audiometry. And if you do that, then you tend to pick up a lot of people because you are going to pick very mild hearing losses that gives you enough time to intervene before someone loses their hearing. But in terms of the pharmacokinetics, we found out that, yes, the concentration, plasma concentration as a function of time in the in the plasma was associated with a 3% increase in terms of every 10 ml was associated with a 3% increased risk of losing your hearing in these particular patients. It was about 102 patients. So in a nutshell, that's what the research in ototoxicity was all about. And I'm now going to go into a different dimension of my work, which is health economics. You've heard a few mention of health economics during my introduction. Yes, I do. I did do some research, and I still do some research in health economics. And normally, when I talk to my colleagues about my work in health economics, there are two things. Normally, they will ask me whether do I want to quit audiology and follow health economics, or they just ignore me and think that, you know, I'm confused. So hence this question, you know, like this is from Madagascar for you, where the zebra was saying, sometimes I'm confused. I don't know whether I am a white horse with black stripes or a black horse with white stripes. As far as audiology and health economics, I also ask myself that question. Am I going to be a health economics with a background in audiology, or am I going to be an audiologist with health economics training? At this point, I don't want to answer the question. I'm having a lot of fun, and I'm going to keep on going. So, but just a few things as we are, you know, mindful of the time, a few things that worth mentioning is my work in social responsiveness. In about 2013, the Speech Language and Hearing Board of HPCSA appointed me to convene a task team to write guidelines for patients who are being treated with drugs that exposes them to the risk of hearing loss. We did that over 2 years, and I think 2015, 2016, we finished that work, and it was finally published in 2018 by HPCSA. And around the same time, the National Department of Health was trying to develop the same guidelines. And when they came to me to consult, I just gave them the document that I was working on from HPCSA, and they took it and, you know, merged it with their document. And the reason for doing that, I was trying to avoid where we have the guidelines from HPCSA and the guidelines from the National Department of Health. If you look at them right now, they are more or less an identical document. And initially, the one from the National Department of Health was written for the developing country context, which I completely rejected. I insisted on us using best practice. And then later on, the director for MDR-TB Directorate asked me to lead a task team of audiologists from, you know, around the country. So we'll fly to Johannesburg and engage and talk about how to monitor patients at primary healthcare level who were, you know, on MDR-TB treatment. And my proudest moment in doing that work was when in 2017 we were invited to Gauteng, and the 5 high-burden, you know, countries, MDR-TB countries, India, Chile, and so on and so forth, were there deliberating. We were invited there to go and share our audiometry work. As always, I expected us to be a sideshow, but I was pleasantly surprised because this became the focus of the engagement. At that time, in 2017, South Africa was the only country among those high-burden countries which had a national program for ototoxicity monitoring that was coordinated centrally. And the data was kept centrally. You could speak to what was happening in KZN, in Mpumalanga, and in the Western Cape based on the data that we have. It wasn't perfect, but the coordination was there. And even when the regimen was changed, we went, met, sat with these people and said, how do we now use the equipment that we have for other needs, because our population still needs hearing healthcare services. It's not just ototoxicity monitoring. And then the other part that I wanted to share with you was in incorporating public health into undergraduate audiology. And you won't believe the pressure that, at the time it was Professor Singh was leading this curriculum review process in the division. When we tried to call the course public health audiology, the amount of opposition that he got from the faculty, because we already have a public health department, so we couldn't have a course in public health audiology. Thanks God, progressive people like Professor Leslie London, he said, no, why not? So we were allowed to call it public health audiology. I'm mentioning this because at the time, we used to do things in a very fragmented way. But during our curriculum review process, and it was a team effort, it wasn't my effort. I just happened to be the person who ended up being responsible for further developing this course. We decided that there are certain conditions or certain elements of our work that can be approached at population level instead of individually, hence the public health audiology. I'm mindful of that. I'll be done in about 5 minutes. Prof, I don't want to embarrass you in front of Prof. So anyway, we had a course in public health, and as it was, we are implementing it. I was invited to London School of Hygiene and Tropical Medicine by the public health for eye care team. It was led by Prof. Daksha Patel at the time, and just to share with us how they've gone around incorporating public health in eye care, and we wanted to adopt that. They had a course that was going on. They offered us to run that course. We ran it for a few years, inviting colleagues from other African countries to come here at UCT. And what ended up happening was we had a course in public health that was informed by real life practice from ordinary people, sometimes not even audiologists, and we came up with a solid course that is now a mainstay in our curriculum. In 2021, the WHO published the World Report on Hearing, and this is something that they are advocating. The picture that you are seeing here, the American Speech and Hearing American Speech and Hearing Association is now advocating for this. And I look at this and I'm saying that over a decade ago, we decided with my colleagues at UCT to say that public health should be something that we teach to our students. My fourth-year students, if you now talk to them about public health, they'll say, no, you do that in third year. They don't think it's a big deal. But right now, public health audiology is a big deal. And as I said, you get the endorsement from the WHO to say that now we need to be thinking in this way, population health. And then in terms of my contribution in developing audiology programs, I saw Prof. Cathard coming in here. We were approached by the University of Zimbabwe via the CBM, which used to have a collaboration with UCT. And a team led by Prof. Cathard, Dr. Lucretia Peterson, Viv, here as well, and myself, we went there and worked with the team at University of Zimbabwe to start this program. And what was amazing about this program was that the first cohort of lecturers in this program was our own graduates. It was so pleasant to work with them. The program started in 2018. The first cohort graduated in 2022. Another program that recently started, this time only the speech side has started. It's in Botswana. The process, you can say that it started in 2014, but they started the first cohort of students in the speech program were admitted in 2023. And this is the program that we've been involved with it every step of the way from the first initial stakeholder engagement. And here it was Prof. Singh, who was part of the, we're paired, now developing the qualification to be registered into the Botswana Qualification Authority framework and so on and so forth. I was invited to go and give an introductory lecture to speech therapists, introduction to audiology module to speech therapists for this cohort of students. And last but not least, as I said, I'll share my plans for the future. So this is Dr. Jessica Maguire. You'll see there Dr. Rhoda, for those of you who know these colleagues. So there are about 1 million children born in South Africa annually, and about 100,000 of them are born in this province, 10,000 right across the road in Mowbray Maternity Hospitals. And an overwhelming majority of those children will not get a chance to have a neonatal hearing screening to check their hearing when they are born. And we know that hearing loss is one of the most common congenital disability. In other words, the most common disability at birth, about 3 to 6 per 1,000. And now work has started. In fact, this work is supported by the Clinton Foundation to try to develop a universal neonatal hearing screening program for babies. And this work is currently we are set up at Mowbray Maternity Hospital. And it's an exciting project that I foresee that at its conclusion will move forward. There are a lot of ad hoc projects. I'll call them ad hoc projects because they, in most cases, we don't talk to each other in screening kids. But I see this as a unifier. From here, we should have a program that, if anything, it will unify the metro. And last but not least, this is a project where I can see my role as an audiologist with health economics training, now reaping the value of that training to make this a really credible project that we are all going to be proud of. And hopefully this will be a project that is now going to enable South Africa to enact policy, or at least legislation, to make sure that all babies born in our hospitals are screened at birth. And in closing, I just want to acknowledge a few people. First and foremost, my beautiful wife, Zandi. What can I say? Nowadays, I mean, you can rightfully say that you are a single mom, because I've decided to live the life of a drifter. And you never complain. I mean, I always feel bad because you have to explain to these boys why, because they ask me, why can't you work in Cape Town like other dads? Why do you have to go to other towns to work? And you never complain, the school runs and sick babies and so on and so forth. Without you, I think I wouldn't be standing here today. It's been a tough journey. You've enjoyed it, and hopefully there'll be more brighter years to come. But so far, we've made it, my baby. And the next group of ladies, I call them Imbogo. What is the plural of Imbogo? Is Imbogod? Imbogod, okay. So this is the lady who started everything. And I'm going to be very frank, Prof. Singh, because you poached me from FETS. No, I'm joking, but you were the catalyst for me to come to UCT. And this is what she told me when she approached me. She said, Lebo, we see what you are trying to do. Come to UCT. We'll support you. She's never let me down. She supported me from the very day that I set my foot at UCT to today. And then there's this lady here, Emeritus Professor Jennifer Jelsma. She also adopted me and included me in her research work, funding, and technical supports. I'm indebted to her as well. And then there's this lady, I can't remember her name. The reason why I can't remember her name is her job is simple, just to make sure that my ego is kept in check. Her job is that, no, Lebo, you are not better than any other kids. And I appreciate that. And then here is my amazing research collaborators in the faculty. I don't know whether Prof. Sinanovic will appreciate being called a collaborator because she's actually my PhD supervisor. So maybe maybe I should do that. But this is the last slide, and I'm going to leave the last slide is, I just want to convey my sincere appreciation and thank you to members of the Health and Rehab Department. Prof. Emerson couldn't be here. I was going to acknowledge him in person. I saw Prof. Cathard just joined. Those are the leaders when I joined Health and Rehab about 16, 17 years ago. And those are the people who have, in a way, shaped the researcher that I am, the academic that I am. Members of this department, I always tell you that we are a department of champions. And I mean that. I've told you, and I'm still saying that this is my home at UCT, and this is a home that I, at any time, run back to, and I know that I'll be welcome. I also want to take this opportunity to acknowledge members of the new generation professorate and GP, of which I was a big beneficiary of that, especially during my tenure as a head of department and even as a head of division. When I was included in this program, it made a lot of difference in my career. At the time, it was headed by Prof. Rob Morel, who he's not here, he's traveling. I would have liked to acknowledge him as well. And now I've been, included into, they are now calling me an ancestor of this program because I've been asked to come and contribute and give back. And with those ways, I just want to say, colleagues, thank you very much. I really appreciated your attention. If you were not here, this would not be an inaugural lecture, but a monologue. I appreciated your attention. Thank you very much.
Thank you very much, Professor Ramma, for that inspiring and delightful lecture. You know, my wife often says I should go and get my hearing checked out. I don't agree. You and I need to chat after this. Ladies and gentlemen, it gives me pleasure to call on Dr. Lucretia Peterson to deliver a vote of thanks.
Thank you for Professor Dyer for this privilege. I think it's only because he's an emeritus VC that I'm going to chance this. But typically, I'm supposed to do the vote of thanks. But the typical thing at UCT is you need to gather information via osmosis, right? And so I wasn't quite sure what this vote of thanks is actually for. And so I just decided, no one told me, so I'm just going to do whatever I feel like doing. So yeah, so that's how I'm going to roll. I also just wanted to just share with you, for those of you who've ever been in Lebo's office or maybe had meetings with him regarding research or teaching or any great plans for for service delivery, you will probably recognize a piece of paper like this with all of his scribbles on there, and with arrows here and there, and then there's a number and whatever, and this is where all of his master plans are born. And goodness gracious, if he loses one of these pieces of paper, there's actually brilliant ideas that will go down the drain, I must say, although the handwriting is appalling. So I want to start off by saying, what I'm going to do just to inform you is I'm going to say thank you to Lebo. So that's going to be my vote of thanks. But I met Lebo in 2007. I can't remember exactly whether I was part of the panel, but in any case, I met Lebo for the first time when he came for his job interview, and he was actually late for the interview because he missed his flight. And they were, yeah, and I think that's, how our journey started. And I think that's also why we got along so very well, because we just make it up on the fly. And yeah, and needless to say, he got the job. He was absolutely the best candidate. And we welcomed him into the division by Christine Rogers, by editing or helping him, with one of his articles. And I think Christine and I thought it was such a privilege to help this guy with, with the article. Lebo, on the other hand, was, wow, these people are so friendly. Because he obviously had different experiences wherever he came from. But in any event, I didn't want to say to him that prior to his and Christine's arrival for about 3.5 years, I was the only audiologist at the university. So I was like, please just stay here, don't go. And yeah, I think we, can forever be grateful for him, for that. I also want to thank him for teaching me that, in a fancy, sleek Mercedes-Benz, you can transport animals in the boot, or maybe even inside. When he had to do Lobola in KZN, that you can ask him, when you see him around, to tell you a little bit more about that. But brand new Mercedes-Benz and all of that. So it's a good value for money car, because it's very versatile. Okay. Also, not shortly thereafter, he got married to Zandi, and I want to thank Lebo for giving quite a number of us the opportunity to experience a traditional Zulu Setswana wedding in the village of Mole Polole, Roshan. And a friend of ours renamed it because he just thought it must be a little bit more posh. So it's Mole Polole. So that's the village that Lebo comes from, and we went to the wedding there. But before the wedding, he was wrapped in lots of blankets, and he was beaten with a stick, and he had to, so I felt quite sorry for him at some point as well. But at that time, I also had the privilege of meeting his parents, his mom and his dad, and I, very promptly greeted them with, and doing the whole, proper era and Emma. Lebo taught me well, but he said I mustn't pronounce his parents' surname because I can't pronounce the surname Ramma properly. So I kept quiet and just did this. Okay, and I could see or get a glimpse into the life that the person that Lebo is, and that it is because of his parents' input. He was, I can also understand why he's so dear mekaar, because he's actually, because his parents are very strict. So when he was let loose, he really let loose. I want to also thank Lebo for, I think, imparting, or sharing with us that, yes, if you want to do research, if you want to do data collection, all that, of course, you need to have two brain cells to rub together. You need to be engaged with theory and with, all those isms and ologies, but you also need to be streetwise. Because if you go and do data collection, especially if you do epidemiological data collection, in places like, say, or the places that Lebo has gone to, he, as he said earlier, has been part of shootings and all of those kind of things. He had to go into gang territories. He had his laptop stolen once. And while he was actually then still talking to the one person, then he saw, oh, there's his laptop going. He spoke to another person and managed to buy his laptop back. So these are the kinds of things that you need to know when you do research. It's not just about sitting in a lab and punching numbers and doing all of that. No. And all of this, has led to, like Lebo said, to the course in public health audiology, which is a pioneer not just in our province or in our country, but in the world, in terms of how audiology could and should be done. And we want to thank Lebo for that and for also making us look good, because we're somewhat associated with it because we work at UCT. Lebo didn't quite mention it, but when he talked about treatment for, of patients with multi-drug resistant TB receiving ototoxic medication at the time, that he was actually instrumental in the audiological service delivery that happened, nationally. Because if it wasn't for him, names dropping and, just checking with, hey, say like, Roshan, say you're the Minister of Health. Okay, say you Aaron. Hey, Aaron, how are you doing? Oh, good, man. And then, that's how he gets an in. And then, boom, boom. Tomorrow, the audiologists being employed in different districts all over the country. But you wouldn't know that because Lebo's a very humble person. So I think for me that, for the 4 H's is how, he operates with humility. He is humorous, he recognizes people's humanity, and he does it with heart. Just one example of how, no, maybe this is too revealing of myself, so let's leave this. I want to thank Lebo as well. He did shared some of his research on classroom acoustics and background noise, and in his work environment, oftentimes I am the background noise. I am the one with the loudest mouth. I always say what's on my mind, etc. And it's not necessarily always the best thing. And thanks to a person like Lebo, look, maybe just give that person a chance, man. Just try it this way. And again, boom, da boom, then it works. So Lebo, thank you for teaching me some humility. I'm not there yet, but I think I will get there one day. And turning my background noise into some more acceptable acoustics. I then also want to thank you for being an audiologist for the people, and therefore a UCT trailblazer. Professor Lebogang Ramma, kia leboga.
So thanks very much, Lucretia, for that collection of stories, because in so many ways, these inaugural lectures are becoming an occasion for the faculty to share its stories with each other. And I think this evening has been one of those. I was interested, though, Lebo, when you started the story of your marriage and your public declaration that you hadn't done anything wrong for the in-laws. I wasn't quite sure that that was a reliable data point or not. But I think the story reminds me that it's so seldom that we have the family of our scholars amongst us. So I want to say to Zandi, thank you very much. And it seems like he's also admitting publicly that he's spending less and less time at home. That's worrying. But thank you very much, because I don't think many of our scholars can achieve what they do without the places from which they come. So to you and your kids, Chiamo, Kumo, and Arenea, thanks very much, because we hope that this part of seeing Lebo in this environment also helps to encourage you that he's valued and appreciated here. I noted also that Lebo started to speak about background noise when he spoke about arriving at UCT. And so I was really getting nervous about whether he would be complaining that there was too much background noise at UCT. I'm glad that he endured it. But I'm also glad that they didn't drive you deaf in the process. Now I'm hearing that your neighbor Lucretia's adding to those noises. But clearly, Tracy, you and I won't allow any of these studies to be done in the deanery because that's becoming a particularly noisy place too. But I want to offer, in conclusion, really, because Lebo, in that journey from Wits to here, it is about your coming into this place of enlightenment, as I often say, this idea that this is the place of the stars, not the people stars, the stars in the sky. So thank you for that journey. I think it's been an incredible one. And I want to say to your sons, if they ask what it is that you do, I would urge you to answer, I make a difference. Because I do believe that is what you do in the faculty. When I came, you were one of the people who listened very carefully in leadership meetings, and now we lead together in national organizations. But really what I'm taking away tonight, in the tradition of these inaugural lectures, the story that you've told tonight confirms very particularly that you make a difference and it matters. Thank you. It remains for me then to ask you to stand as the procession leaves and then to join us for some refreshments outside. And to the colleagues, thank you very much for being online. Thank you.